Hello, it's Thursday Night Live, time for Ask Melissa Almost Anything, where we talk about your life and your body, where we believe your health is your responsibility and that you always have a choice in your health care. We believe pain is not normal. I'm your host, Melissa, with Nephew Physical Therapy. Tonight, we're talking knees. The bee's knees. Everybody has two. Most of you do, right? Most of us have two knees. It's a fascinating joint. It's simple and it's very, very fascinating. Let me tell you tonight, I'm going to take off my PT hat and I'm going to put on my wife hat for just a second. See, I can talk about my husband here as his wife. And know this. He is not old. I'm just going to say that before we even get started. So my husband, Mitch, very active. If you didn't know, that's actually how we met. Hi, Hannah and Lori. Good to see you. Mitch and I met actually on the softball field. We were both playing a lot. Let's just put it that way. Nights and weekends and all that kind of stuff. And we met being active together. And so being active together has been a priority for us for our entire relationship. We both have played softball together. I like to play volleyball in the winter. He likes to play basketball. He's played dodgeball. Moving is very, very important to both of us. And I will tell you, as his wife, especially in the winter, finding activities for Mitch to get outside and do is so important. So this winter, his work team put together actually 2 basketball teams to play rec basketball. Awesome. So excited, so supportive, happy to see him go out, be social, play. What was funny, as the side note is as the, I think he said the oldest guy on the team probably played the most minutes because it's Mitch. He's a runner, he's lean and mean and just goes, right? Well, unfortunately, on a Sunday afternoon playing rec ball, he tweaked his knee. Now, spraining or tweaking your knee is pretty common. Kind of like spraining your ankle. It can happen. And he said he noticed it early on in the game, just a little tweak. Tried to walk it off. Many of you might relate to that, walking it off. And then kind of pushed it over the limit. And so watched him limp for a couple days. And as his wife, I'm like, you need therapy. I'm not your therapist. Let's talk to Christine or Naomi. So send him to therapy, all right? They start working on it. He's making good progress, right? Like I'm watching Naomi put him through the paces and he's doing more exercises and all that kind of stuff. And then spring break / COVID-19 hits. So he's a little bit gimpy. He's had a couple of, things that have set him back a little bit. We go on vacation. We're gonna hike the second tallest mountain in the Smoky Mountains, Mount LeCount. Note, I didn't make it. But he did because somebody had to keep up with those kids who kept climbing to the top. I, of course, was worried about him. I was like, please be safe, please be okay. He goes, makes it all the way to the top. Apparently, though, on the way back down, it buckles again. Rest of the week, it's more swollen, doesn't move as well. I ended up, again, the world is changing. You guys all know how that week of March 13th kind of things started shutting down. We're out of town. We drive home. I drive the whole way because it's not comfortable for him to sit that whole way back. And then, of course, things start closing. And we make adjustments at the office that I'm the only one treating patients. And I'm trying to help him at home. But again, I'm not his therapist. I'm telling you, friends, we can't fix our spouses in any aspect of life. And so what I noticed over the weeks is I just didn't look like his knee was getting straight. And this is why, again, I can't treat family. Because finally, Naomi, we brought her back a couple weeks ago. I'm like, you got to see her. His hip is totally weak. Now that is where the knee gets to be such a fun conversation, of course, because everybody knows I love the glutes. My favorite. And again, why I needed somebody else to put eyes on him. What was happening, and yes, Mitch had an injury, and we're going to kind of talk about the tale of 2 different knees tonight because you have the knee that gets injured as in Mitch's situation where he played basketball, he tweaked it. You know, we have trauma of some kind. We're playing sports. We tripped and fell at work, at home, whatever. And then we have the knee that just starts hurting for no good reason. But what's happened in Mitch's situation is because life happened, because COVID-19 happened, just didn't stay on the path of treatment, which I'm going to interject this right here, folks. Physical therapy is a commitment over time. This situation has proved to me what I've known for 20 years is that you can't just rehab on your own. You need a guide. You need somebody to walk beside you to say that's working, that's not working, let's change that, let's add this, let's take this away, let's do those things. And Mitch's knee is getting a little better. He's been back in therapy for 2 weeks with Naomi. The biggest thing is he's been so weak in those butt cheeks. And let me explain to you why the glutes are so important to the knee. All right, so the knee is a fairly simple joint. It's a hinge joint, okay? So think about the door in your bedroom, okay? Opens and closes, right? Opens and closes. Now, if it's slightly off, right? You can't close it all the way. Either it's swollen. Does it happen to you, right? Like with lots of humidity here in Michigan, our doors kind of swell and they don't close quite as well, all right? That's like your knee. And then, or it's slightly, again, just slightly askew. Or it makes me think of if you have a sliding closet door or a pocket door. We have lots of pocket doors in our house that we bought. And it gets slightly off and it's like, oh, you just have to jerk it to get it to move. Your knee is made to work as a hinge, 2 directions, nice and simple, okay? You've got that femur, strongest bone in the body, coming on down, sitting on top of that tibia, bending and going, okay? You've got this happening. By the way, if you've got specific questions, put them in the chat. But I always want to start out with an anatomy lesson here, so we're going to talk about that anatomy. But please, if you've got any specific questions about your knee, put it in here. Otherwise, we'll just keep talking. So that knee hinges, okay? It's supposed to go 2 directions. What we somehow forget when it comes to the knee is that the knee is so significantly driven by what's happening in the hip, okay? Because the femur, which creates the top of the knee, is part of it's the ball that sits in the socket in the hip, okay? And if we get a little bit crooked, okay, a little cattywampus, a little bit shifted, whether that's in our hips or in our knees, that knee will start caving inward. This is a common thing I will see in the aging population. When I say aging, I'm talking like north of 75 years old, okay, where maybe we're sitting too much, okay? Don't stop moving, don't ever stop moving. And what happens is, I'm gonna try to show you here, right? This is just from the knees down. What you're gonna see is that knee comes in, all right? It's gonna just kind of cave down on you there and it falls in. And what happens is, oh, my knee hurts, my knee hurts. Yeah, but you're not getting any stability from that hip. And that's actually, in a healthy 42-year-old like Mitch, that's what's happened. He stopped using the muscles in his cheek because he couldn't fully straighten his knee, so he couldn't take a full step through, and they are a use it or lose it. So thankfully, with specific strengthening and guidance and all that kind of stuff, we are building that glute back up. I should say Naomi is pushing him forward to build that glute back up because 1, he needs the strength. 2, when you strain or sprain a ligament, it just needs time to heal. And this length of healing in that knee is going to take some time. He's had some setbacks though, right? It's buckled, it's tweaked, he's had some things happen. Maintaining that strength in that cheek to provide support down the chain, so very, very important. I want to address Lori's comment here in the chat that says she has a Baker cyst behind the left knee. Oh, I'm so sorry. So is there anything she can do to improve it or change it? All right, so this is not medically sanctioned advice, everybody. So I hope this makes you laugh. The best advice I ever got for a Baker cyst, because they're actually quite common in the wrist too, is you basically beat it with the Bible. Now why? Because the Bible is the biggest book in most people's homes and you're supposed to whack it. and break it apart. So my advice is there really isn't anything that you can do. Sometimes they do break apart on their own. Sometimes when you push on that, right, it will do that. I mean, a Baker's cyst can be surgically removed. And if it does create enough problems, if it's affecting function, depending on where it's placed in that knee joint, it could be removed, okay? But what I do push back on, right, is that it's bugging your knee, okay? So we established that. We know it's somewhere in that knee joint. I always push back to say, is it really the cyst that's bugging you, or is it something else in the knee? And I guess that depends on the symptoms, right? Because, and if I've said this to you guys before, I'm kind of a broken record. I'm gonna say it again. Why is it that we as humans, when it comes to taking care of our bodies, see things so narrow-minded? We go, my knee hurts, what's wrong with my knee? The privilege of evaluating a young athlete this week, patellar tendonitis. I am telling you, there is not a thing wrong with his knee. Ligaments, check. Meniscus, no problem. The tendon's not even that tender. No swelling, no redness, no nothing. But when they're squatting, running, jumping, sports, pain stops him. What we had to do is we went up a little bit further, and for somebody, again, young, healthy, and strong, the weaknesses that we were able to identify in the hips and in those glutes, all those different directions, are causing him to break down at the knee. So it's just like the shaking steering wheel in your car. Nobody buys a new steering wheel. I have yet to find somebody on the planet who bought a new steering wheel when it started shaking. Okay? We just don't do that. We know that a shaking steering wheel is the symptom. Okay? When we decide we're going to start addressing problems, we're going to start looking for the cause, we have to peel back layers. We have to go, so why is that? Right? So talking back to Mitch, with Mitch's situation, he planted, he cut, and his knee gave out. Now, hindsight, I don't know if it was because he didn't have enough strength in his hips or whatever, or did he just step on somebody's foot? Was the ground wet? Like, there's different things in that traumatic situation versus something that just develops over time. And when we look at the car, most of us are not mechanics of vehicle mechanics, but we know that a shaking car can have a variety of different reasons. From as simple as you went through a pothole to going over the railroad tracks to a flat tire or a tire that's light on air to things that are really breaking down like the axles and the alignment and all that stuff. But we're looking for symptoms, and that's why as a physical therapist, when you tell me what's going on, the more you tell me, the faster I can figure out what's going on, because the body really very simply gives us a lot of that information in the form of symptoms. God did not intend for us to be in pain. I don't believe that for a second. I believe he created perfect humans before sin entered the world. These bodies were designed to last for centuries, I believe, right? Methuselah lived almost 1,000 years, and then God started over, right? At the time of Noah, God started over. And so he has made us in a way that we can heal, we can recover from stuff, we can build strength. In Mitch's situation, we can rebuild that strength and support that knee. But it takes effort, and it takes time to figure out why that is. And so that is where digging into that a little bit deeper is super, super important. Again, if you're joining us, please don't be afraid to put a question, a comment in the chat. Let us know that you're there. Did throw out a couple of questions this week out on social media and Facebook, and I kind of want to get to the idea of the joint replacement, especially knee replacements. I was reading an article put out by one of the insurance companies that actually said joint replacements are significantly on the rise of people in their 60s. Now, it's funny because in some parts of the world we start talking about the fact that 40 is the new 30, 50 is the new 4, whatever, right? Like, in a lot of ways, we have learned amazing health ways to take better care of our health, better food consumption. We know we need to sleep more, all of these things. And We see people who are much older looking much younger because they're taking better care of themselves. But what we see is there can be such a division in society between how active we are and how active we aren't. And that idea, the question really is can I expect to get a joint replacement? Is that just normal? Right? Lori's like, both knees eventually need to get done, bone on bone. Oh, like, that sounds, I hate to say it, Lori, that sounds hopeless. And the question is, how do we stop that? How much earlier do we need to intervene in people's lives? What does it take to get people to say, this isn't normal? How do we get you to say, pain is not normal at any stage of life, and that we need to get it? Yeah, and Lori, you're only 52. You are crazy young. 52 is so young. And this idea that I automatically gonna know that at some point I have to replace my knees, they weren't designed to give out. Okay, God did not say, oh, well, you get, at 50, 60, 70 years, they're done. Time to get a new one. No, so the question is, why are we not taking good care of our knees? Why is that knee so vulnerable? Again, we have traumatic stuff, right? We have people who have ACL tears because they were cutting, planting, skiing accidents, trip and falls, household accidents, stuff that happens on the farm, right? Like, that's gonna happen, okay? But this wear and tear on our bodies over time, I think, honestly, in my opinion, it's that we sit too much and we're weak. So think about this, all right? Do you know any toddlers in your life? I don't know if you have any in your home. When you look at a 2 or a 3-year-old and you watch them play on the floor, can you see this? They've got their toys right in front of them on the floor. I won't even demonstrate it because I certainly can't do this, all right? And again, this is kind of a Melissa-ism. This is based on my years of experience and kind of some stuff that I've pieced together. So is there scientific research? No. But have I been testing this theory for a long time? Yes. So if you look at those 2 and 3-year-olds, they can squat down, right? Feet on the floor, butt right off the floor, just sitting there, right? Just hanging out forever. They can play like they're squatting, but their knees are right up in their chest. Knees aren't forward. So, right, as somebody who's weak, if I'm gonna squat, right, watch this, right? I'm squatting, I'm here, okay? Just so I can be able to balance. If I'm a kid, like, I can't even do this. They're like here. Of course, my belly gets in the way, and I can't sit there, and I would keep my butt off the ground. Like, that's not normal for adults. I'm just not strong enough to do it. And so, that's where I have to hang off. Just a second. I have some visitors. Sorry. This is what real life during COVID-19 looks like. Hi. Cooper and Grady wanted to pop in. This is real life here, folks. And of course, every time that there's an interruption, a wrestling session breaks out, right? So there we go. Okay, boys, I'm trying to teach something. Can you give me a... All right. Honey, we're not talking about that right now, okay? I'm a little busy. Okay, go ahead. Okay, well, there you go. Real life happening right there, folks. I'm sure that when you're trying to have your Zoom meetings and whatever you're doing at home right now is pretty hard. Okay, looks like Hannah put something in the chat. Hannah hopefully showed a picture of what the baby squat looks like. Perfect. I'll have to look at that later, Hannah. Thank you. And when that baby, yes, that's what we need. Hannah found a picture of it. So when we look at those little kids, they can squat there forever. I can squat there for 10 minutes like that, let alone 1 minute. Here's my theory, is that as kids, active kids, right, where we're out moving about and we're playing, we use our hips and our glutes and our butt and our hamstrings and our abs all the time. But at some point, we sit in a desk, right, we start school, that varies now, right, 3, 4, 5, 6, 7, and then we sit for the next 12 to 18 years. Now, do we notice it that much during that age? No. What do we also notice that has changed in cultures? We actually are sitting increasingly more, which is where us sitting at home right now, kids more on screen time than ever because they're doing school at home. We've got so many changes happening. And does it show up in kids right away? No. but we start to decrease how much we rely on those glutes to support us over time. And so when we lose that strength, we're now putting more pressure on knees. When we're talking about getting stronger in the glutes, we talk about squatting, right? We mentioned squats. It should not hurt your knees to do a squat. Think about that. The last time, if you like to exercise regularly and you did a squat, did it hurt your knees? It's not supposed to. Did you know that? Because you're probably overusing the knees because you're just not getting enough support from those big, beefy glutes, obturators, all those deep muscles in there. So, and know that I'm trying to get my thoughts back together because those Meiste boys came and crashed my party. This is the quiet little tiny part of my world. It's our bedroom. I've got my home office set up here, my computer, I've got my phone. There's a door because there's not a door in all the other rooms of the house. And of course, they couldn't help themselves, right? They needed to come say hi, so they said hi. So anyway, when we're talking about being strong in there, and so the question is, over time, as we get back to that discussion about joint replacements, knee replacements, is that normal? I would push back to say we are just not staying strong like we need to be over long periods of time. And so how do we get to do that sooner? And like Rachel is asking, I'll just say are you saying that PT can be used preventatively? If my knee has just started hurting me, but not too bad, can I come to be PT before my knee hurts horribly? Hannah already answered, yes. Yes, and let's explain that, okay? Because remember, we said the tale of two knees. One, we have a traumatic injury, or we have somebody who just wants to be active, take care of their kids, go for walks, maybe go for a run. That will be running, by the way, is not, if you like to run, I'm not going to tell you to stop running just because you have knee pain. Keep that in mind, folks, all right? Because that is not, if you love to do it, you should do it. We should figure out, again, address the symptom by getting to the root of the problem, all right? And so that is what we're saying is if you have a history of knee pain, the sooner you get in, we can address that, we can teach you and kick you out. We want to, pain is not normal. Pain is not normal. And so if you are having pain that is interfering in the quality of your life, if it is stopping you from playing with your kids, going for a walk, doing whatever you need to do at work, a variety of different regular everyday activities, if it is getting in the way of that, you need to do something about it. All right? And so Christine's follow-up question here is, what are some of the glute exercises we do to support your knees? All right. So let's talk about this a little bit, and I think I can demonstrate a couple of things here. This depends on how weak you are, how much in pain you are. Do you have back pain or hip pain to go with it? All right. But typically, what we start our clients out with is the ability to contract the glute max, which is front to back motion, okay? So what we're talking about here is the first of all, and this is what's hard to do, but I'm gonna do my best to do it in a video where I don't have somebody to touch, is doing a pelvic tilt, okay? You start with the ability to do the pelvic tilt. Now, we're gonna have a little fun here because men just don't move as well through their hips as women. It just seems to be true. Not always, it's not 100%, but a lot of times. And so the ability to move the pelvis, now here's the tiny picky detail, is that you gotta be able to do it without holding your breath and sucking in your gut. And this is the challenge with how a lot of exercises are taught in the exercise world, outside of physical therapy, is people are taught different positions or forms, which if you are strong, yes, you can squat with an upright chest. But if you are really weak, squatting with an upright chest is going to cause you to have more back pain and knee pain. All right, so what I'm going to try to do here, okay, because the question, and this is Facebook Live at its finest with my I have a new phone holding gadget. Just a second. Okay, wait. All right, let's try this here. Okay, hold on. Let's see. Hey, right? Technology is great when you know how to use it. Okay, perfect. So what I'm going to start out with, we're going to see if I can do this here. I don't think I have the camera width to do this, and my studio's not as fancy as I would like it to be, Christine. So here, let's do it like this. All right, let's try. Oh, this is so funny. I hope you guys like stick with me here because I'm just trying. Okay, so let's talk about a bridge. All right, and again, I need this to be a little closer to the floor. My one-man show here is pretty funny. Yes, Christine, good. Please keep laughing. Okay, here we go, friends. All right, so I am on the floor. All right, got it. Okay, perfect. Technology is kind of working. All right, so pelvic tilting is rolling your pelvis, all right? It's not going to be easy for you to see because it's small. This is small motion, okay? And what I'm basically doing, there's a couple ways that we describe it. One, pinch your cheeks together like you're trying to pick a $100 bill up off the floor. I used to say a quarter, but nobody's, squeezing their cheeks for a quarter anymore. It's $100. So you want to pinch those cheeks together, and what you're going to do is you're going to roll that pelvis backwards, okay? I'm rolling backwards like I'm taking a bowl of spaghetti, setting it on my belly button, and I'm tipping it up towards my mouth, all right? So I'm rolling my hips this way. When I do that, I also, which you can't tell, is I push through my heels. So what I'm going to do here is I'm going to roll backwards, but with my my COVID-19, have you heard this? Yes, right? Like if you put on a few extra pounds because you're home all the time, the COVID-19, roll back. You do want that belly to be loose when you do this, because if you're bracing and holding your breath, you're not engaging the right muscle groups, okay? So we start with that pelvic tilt. That is the first place, because if you can't engage the glutes here, progressing to a lift will either tick off or irritate your knees, or it'll bother your back, okay? So what we do is we start out with a tuck, roll, lifting motion, okay? And then I hold that, all right? I'm focusing on engaging my butt cheeks, all right? I'm pushing through my heels, and I'm holding, okay? We start out with, these are some of the basic things we start out with because we want to make sure that we can hold our muscle contractions against gravity, okay? Now, ultimately, the best thing to do long-term is squats and lunges, stuff in standing, which is more dynamic and more challenging. The problem is we don't want to skip a bunch of steps like we would. We don't have our babies come out of our wombs and they start walking, okay? And when we are in pain, if we have knee pain, back pain, hip pain, whatever, right? We're talking about pain in that lower body. We're talking about the knees today. When we have that pain, we have to make sure to kind of systematically see how those muscles are firing and working, okay? So the first thing we start out with then is bridging. That is traditionally where we start. We're starting to engage the butt cheeks. We're starting to engage the hamstrings. And I also want to add this, because you won't feel it, but you'll start to engage those lower abdominal muscles because they will follow along. So this, to me, absolutely is the definition of a core exercise. Okay, and so doing that. Here's the other tip, right? Again, this is where the eyes of a skilled therapist watching you do your exercises, which I'm going to head down a rabbit hole again. I'm going to at least give you this warning. This is, again, is for my friends who do not live in the greater West Michigan area. Christine, I'll come back to your question in just a second, because otherwise I'm going to lose my train of thought here. Working on this Facebook Live stuff. If you don't live in the greater West Michigan area and you are looking for what a good physical therapy clinic is to choose, one of the things that really is important to me is that one-on-one attention, which is what we have always done, with the exception, like 0.001 time we saw somebody overlap because of a scheduling challenge. But what we do in our clinic is we work one-on-one with you. Why is that so important? Because if I am going to ask you to do exercises that are not easy, which is what it should be, because if you can just get exercises off the internet and just go to YouTube and fix yourself, if that's successful, do that. Challenge is I haven't found anybody who's really been able to resolve some, consistent painful knees, backs, etc. by just Googling what to do, all right? And so what we're trying to do is start to get you thinking. Of course, these videos are designed to get you thinking about the fact that your health is your responsibility. And I want to encourage you to use your health insurance dollars for health care, not sick care. Because if knee pain, for example, is getting in the way of you being active and moving, that will negatively affect the rest of your health, right? If you can't move well, it affects your lung health, increases your risk of diabetes, increases your risk of heart disease, all of these other major medical things, which of course are in the news these days, right? People who are unhealthy are at greater risk of all kinds of other things, and so we need to get to that stuff sooner. So I highly recommend finding a physical therapy clinic, if it's available, that does one-on-one care, all right? Because we are going to make sure that you're using the muscles that are weak, because your body's been doing a fabulous job of compensating and making up for that, okay? How long do I hold this? I like to start out with a goal of 20 to 30 second holds, okay? Now, the other thing is to make sure, again, I'm giving you all the nitpicky details here, okay? So we've done the pelvic tilt, we've squeezed our glutes, we pushed our heels into the floor, not our toes, okay? And that we're going to then hold, but we want to make sure that those knees, okay, if I'm in this position, are way out here or right tight together. They need to be lined up with my hips. And some of you, right, have knock knees, some of you have bow-legged knees, and so trying to be in a neutral hip position is going to be the best position for you to be strengthening in, okay? So keep that in mind. Now, I know that Lori had asked the question about hamstrings as well. So here's the interesting thing that you will find when you do the bridge, for example. When you are bridging, if you are not strong in your glutes, your hamstrings will cramp because it's compensating. So what we find, this happens a lot, when people don't know how to use their glutes because they've stopped using them because we have no butt, all right? What happens is the hamstrings will get overloaded. And that is a surefire way to find out, okay? Which is why we initiate the motion with engaging as many of those glute muscle fibers as we can to get them squeezed nice and tight, and then lift through the heels to push up and engage there. So from a physical therapy perspective, we usually have people to do, we start around 30 seconds, try to work up to 60, but focus on being properly aligned. Should not hurt your back, should not hurt your knees, should not hurt your neck, by the way, for those of you who are trying to use every single muscle in your body to produce a glute contraction. Trust me, it happens more than you think. And then you're holding that, so 4 to 6 times. If you do that fairly consistent, you're starting to use gravity and you're holding yourself up. Here's the other side of that, is you are going into extension. All right, I'm sitting here on the floor in flexion. I am bent forward, okay? Extension is when we start to bring our chest and our knees in that same plane. We open up, so that stretches out the front of the hips as well. So that is a very, very good thing. All right, I want to address what Darlene said here. I read that the V-sit is bad for knees and that you should try to keep kids from doing it. Oh, I love this question. Is there truth to that? If yes, can that cause, hold on, I gotta see more here. Can that cause long-term damage if you continue to sit like that well into, I think, adulthood? Yes, 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 yes. All right, so I am not a peds therapist, all right? So there's your clarification here. So what Darlene is talking about is when kids, and I can't do it, because they do this on both legs, all right? And they roll in. I absolutely cannot V-sit. V-sitting indicates weakness in the deep rotating muscles of your hips, okay? And what it will do, because your hips are not designed to roll in that much, all right? When we're going to create excess motion, it's not happening at the hips, it's going to happen at the knees, okay? And so it's going to create a very loose inside of the knee, which is your MCL, your medial collateral ligament, and rolling in, okay? So you have that internally rotated position. What happens then is when somebody is walking who has that, what we see is those knees start here, but when they walk, you ever see knees just roll in? People are taking a step and they roll. Instead of going straight like this, they roll and rotate. If we go back to the beginning, we talked about that knee joint, how it's a hinge, okay? And so as that weakness in rotation happens in the hips, as we have over time depended on that V-sit position, and we continue to do that, you will continue to see that weakness in the hip. You'll continue to overuse and stretch the inside of the knee out, And then that shows up when we then get into a functional walking, standing, stair position. We're going to continue to then rotate over that knee instead of hinge. All right? So yes, those are the kind of things, to go back to the earlier discussion on does everybody need a knee replacement? Knees that are doing this repeatedly over time will eventually become bone on bone, because we're wearing out the cartilage and the soft tissue that's supposed to support the knee, because again, we're not hinging the knee, we're rotating it, because that femur is not stable up in the hip socket as it comes down into that knee joint. All right, so avoiding V-sitting, absolutely try to avoid that. I'm pretty sure I didn't let my kids do it because I knew that that wouldn't be great for their development. Does it mean that it's hopeless? Absolutely not. Because again, we can strengthen into any decade. Okay? You can get stronger in your 90s, folks. So if you can get stronger in your 90s, you can for sure get stronger in your 30s, 40s, 50s, 60s, okay? And every other decade. So what needs to happen in that situation is, and this is where as therapists we get in there and we actually can measure strength. I don't know if everybody realizes that we have a system, a grading system, where I can determine weakness from one hip to the other and compare side to side to get a whole overall picture of what's happening in the hips and pelvis, okay? So we measure that. What we also measure is the strength between the quads and the hamstrings, the front of the thigh and the back of the thigh, all right? And those hamstrings are super, super important. But the question that often gets asked, again, in the context of knees, I know I'm talking a lot about the glutes, okay? Because again, I think that the glutes get missed too much when we, again, focus solely, because the question isn't, well, the first question is, why does my knee hurt? And then the second question is, what exercises do I need to do to strengthen my knees? Here's the challenge. The knee is a joint, okay? It's not muscles. All right, so think about that. When we're trying to strengthen a joint, we're actually trying to strengthen the muscles that support it. Okay, so the question should be, as again, we encourage you to critically be thinking through this stuff, all right? Why? Ask myself why in every aspect of my life. Why am I demonstrating this behavior? Why am I making this decision? Why do I want my kids to do this? So we talk through the why. We ask ourselves, why do I want to have a stronger knee? Well, is it strength it needs? If it's stability, that's a slightly different question too. Are we talking about balance? Are we talking about agility? But we need strength before we really can do any of those kind of things. And the strength really does need to be happening in the glutes. Now, of course, the exception, that is very true here, is when you either have surgery or you have a knee injury of some kind. You tear your hamstring, a partial tear, partial quad tear, you will actually have loss of muscle. That happens. And when we have loss of muscle strength and bulk, and when we measure that, we do build that up, okay? So I am not saying that when we look at the knees, we're going to ignore the quads and hamstrings. Absolutely not, okay? But traditionally, most people don't need to be doing more. They don't need to be stronger in their quads unless they really have not used them for an extended period of time. They are significantly way stronger than the hamstrings, and in regards to then how they relate with the back. Speaking of hamstrings, one of the things that, one of the thoughts I had in thinking about talking about the knees tonight was most people that I see are always stretching their hamstrings, okay? Pick on you runners out there, or somebody you know that runs. How much do you want to bet that this exercise, right, we're bending forward and we're reaching, is always something they do? We're always stretching those hamstrings. Oh, they feel so tight. Oh, they feel so tight. So stretch and stretch and stretch. But they continue to feel tight. Well, the question again is why? Are they actually tight, or do they just feel tight? Again, anatomy gives us so many answers. So here's what I want you to think about. That hamstring, yes, it attaches to the back of the knee, but it attaches to the ischial tuberosity. The ischial tuberosity is your butt bone, right? If you were a skinny kid and people didn't want you to sit on their lap because you had a bony butt, right? That is the bone that it attaches to. So your hamstring attaches to your pelvis, right? Pelvis, that bowl. We're going to go back to that spaghetti bowl, right? It attaches to your pelvis. So, if my pelvis doesn't move, oh wait, I think we already talked about this. If my pelvis doesn't move and tilt backwards, why would that hamstring that attaches to it, why would that move or extend? Okay? I hope this is making sense. Let me show you here. I'll do the best that I can, all right? Because we're going to go back to that pelvic tilt. That's what's going to happen here, all right? So I'm on my back again, all right? So I'm going to stretch my hamstrings and oh, that's so tight, okay? But again, it attaches here and it comes all the way down into my butt cheek, all right? But if I can't roll my hips, okay, if I can't do that pelvic tilt, if I can't move it backwards, is it the fact that oh wait, let me go back one more step. What attaches to the pelvis? The low back. So we have hamstrings to glutes and pelvis to back, right? How many people have painful tight backs? Please give me a back rub. Please give me a back rub. No, give me a glute rub. But that's a different story because those muscles are working hard. So if my back is tight, my pelvis doesn't move, my hamstrings don't move. Is it true in every situation? Not necessarily, okay? So again, this is not a one size fits all. However, when we're talking about aches and pains that are not driven by trauma, that are not driven by an injury, accident, sports, trip and fall, any of those kind of things, and we start looking at how we have not been utilizing our bodies well because we sit too much and everything is drive-through and we're stuck at home and whatever it is, right? All of these lifestyle things, right? Which again, first world problems, we have those. We sit too much. If that back doesn't move, if that pelvis doesn't move, the hamstrings won't move. So we go back again to the pelvic tilt. We pelvic tilt. We do that as a warm-up exercise. We do that for a couple minutes. Then we're going to do our bridging. Then we want to engage those hamstrings, all right? So again, not set up well for this, folks, but I'm doing the best that I can. Hamstrings, the best way I like to do them, and of course I can't move my studio around here fast enough, but I'll get better at this, is laying on your back and put your feet on a chair. Okay, so I'm going to try to demonstrate it. I'm going to put my feet up against my desk. All right, so we'll pretend that, there you go, that this is a chair. All right, so what I'm going to do is I am going to pelvic tilt and I'm going to bring my knees up. Okay, let me try to adjust that screen again. All right, we're going to come back down here. So funny. This is hilarious, right? I hope you're being entertained. So we're doing this motion. It's straight up and down. But I don't want to do that until I've pelvic tilted because when I lift up the first time, I don't feel it here. I feel it in my back, okay? Because my back is all tight because I've been sitting too much today and all that stuff. So I take my heels, I dig them down, I bring up, and then again, we're going to start with the hold, all right? Now, because it's my desk, I can't get a good contraction, but you want to feel that here. And again, I'm just going to hold that. I'm going to hold that for 20 or 30 seconds if I can and focus on that contraction. But it has to be done in conjunction with the pelvic tilt. You got to tilt that pelvis and engage those hamstrings. All right, so Hannah's asking about ITB syndrome. Okay. Iliotibial band. All right, let's talk about that here a second. It is the band of fascia that goes here along the outside of your thigh, okay? And in a lot of us, it is really tender. However, my first question is it tender on one side or both sides? A lot of our symptoms don't show up on both sides, right? So why would our body be exactly the same? It's not exactly the same. It's usually crooked, right? It's a little bit cattywampus. That's why we don't have usually pain in both knees. We often have pain in one knee because some of those things that shift and change and all that kind of stuff. So, IT band, this is my opinion. And again, as in every video, this opinion that I give tonight is based on not touching you, not evaluating you, not teaching you, none of those things. So, do so at your own risk. Do so. Try them out. Again, everything that we're doing tonight is not overly aggressive, okay? But it's done in a way where you can start trying to move in the right direction. But iliotibial band syndrome, okay, is pain that typically is in the outside of the thigh. So as a therapist, I ask the question, why? Why are people painful there? Okay, so what am I going to look at? I am going to look at how strong are the glutes and the hips. Are they strong enough? Okay. What does the knees look like? Are they knock-kneed? Are they bow-legged? Is one more than the other? All of those kind of things. Because it's more than just, I have symptoms there, right? And we put fancy terms on it called ITB syndrome. Okay, great, you have a syndrome. Oh, good, now we've labeled it. Except that, again, is the symptom. It is not necessarily the problem, okay? If you actually tore that fascia, okay, that would be the problem. But again, I'm going to ask myself, why? Okay? You look up at the ceiling in your house and there is a wet spot. Do you just replace the ceiling tile or the drywall and say, oh, I fixed it? No, that is not what happens. I see a wet spot in the ceiling and I think, is the roof leaking? Okay? Or is there something between the ceiling and the sky that is creating a problem? But again, in the human body, we go, it hurts here. Must be ITB syndrome. Well, why? So you're telling me if I stretch it and massage it and just work that ITB, that outside band of fascia, it's going to be better? Well, if that is the problem, it would be. But traditionally, again, when we tie all these different things together, it is our job, especially in non-traumatic syndromes, okay, runners, right? What they're doing is not traumatic. Runners are great at going forward and they exercise and they're committed and all those kind of things, but your body will break down at some point if somebody else isn't doing their job, okay? And so it is our job then to look at that painful region, because we in this country are motivated by pain, and remember, pain is not normal, to then dive in there and find out why. All right? So to me, I can see somebody who has patellar tendonitis, who has just general knee pain, who has ITB syndrome, who has just those kind of syndromes, all could have the same underlying weakness, tightness, range of motion issues, but have their symptoms in different areas. So again, the symptoms let us know where in your body you're breaking down. Where is the weak point? Where is the stress point? But what we find is who is not doing their job the way they were designed to do it. Teams, sports teams specifically, or, oh, this is an even better example. I don't know how many people watch NASCAR, but if you watch a team change 4 tires in, is it 8 seconds? Like, it's crazy fast. Like, and if one person misses one lug nut and misfires, the whole team falls apart, right? And it costs them time, which costs them positions, which costs them position in the race, which costs them money. Okay? All of that stuff. They have to be a finely tuned machine to change 4 tires in the blink of an eye, basically. That is what we need our bodies to be. And the more we expect out of them, okay, the more we push them, the more we move, the more they'll let us know what isn't working. And what I am saying is, take your body out for a spin. Keep working. Walk more. Decide to start running. Do the squats. Do whatever those things are. Climb the stairs at Mount Pisgah. Do all that kind of stuff. So, very, very important to do those things. And when you do that, you'll find out if something breaks down, and then we figure out what that is. We fix it, and we send you back out into the world. Ryan just jumped in and had a question. He dislocated his kneecap a few months ago. How does he strengthen to prevent this from happening again? Okay, so we're going to talk about the location of the kneecap as it sits in that knee joint. So what we talked about earlier is it's a hinge joint, okay? Now what keeps that all together is you have the big quad muscle, okay? That quad attaches into your patella, your kneecap, and then that sits right on here. There's a circle that sits right there, and then it comes down and attaches down here below the knee with your patellar tendon, okay? So when you dislocate that kneecap, it pops out of its groove, okay? So there's kind of a groove here, all right? So preventing, so why does it happen? Well, sometimes people are just walking and it dislocates. That's an indicator of rotational changes. Again, knock knees, hips rolled out, all that kind of stuff, okay? Where, again, that femur is rotating inward or rotating outward over a period of time. If we're talking about a dislocated kneecap from trauma, that is a little bit different scenario, which can be, you know, getting hit. I think of a football injury where, you know, hit sideways, rugby, that kind of stuff. But most of the time, we're not necessarily having that from a traumatic injury, okay? So how do we keep that kneecap from dislocating again? Well, contrary to popular opinion, I don't actually, again, without touching, evaluating, doing those kind of things, I am less concerned about that quad, okay, which is what actually controls the kneecap in its place. And I am going to be more concerned about how, again, everything else is working in that area. So I'm going to sound like a broken record. I would want to make sure that we're getting good hamstring contractions, we're getting good glute contractions, and we're doing it all with good alignment, okay? So what will, again, if you have a kneecap issue, it often means that it, again, slid out. It's not a socket, it's not a joint, but it slides out and in, and you're more likely to have that happen again because some of those soft tissues that hold it in place have been stretched out. So what we need to happen in that situation is those quads are often very strong and they're pulling. So is the knee, again, straight up and down, or is it a little bit torqued? Is it a little bit rotated? So we start out with those pelvic tilts, we start with bridging, and we start with those hamstring walls slides. We do every single one of those exercises squared up, okay? Again, not knees together, not legs out. We do them lined up, nice and straight, and we work those muscles, and we start that direction, okay? We always start most patients laying down or sitting down to isolate. One other exercise that I haven't mentioned anywhere along the line here that we also hit very early and often with patients is the clam. And I've mentioned that I think a couple other times before, but with the clam, I don't have my band here with me. Let me turn this down again. All right. So the clam is where we start to get the outside of the hips, that lateral motion, okay? So I'm laying at my side. What I would do is I take an exercise band and tie it around my knees, and I'm going to pull and come down, okay? Now when I'm doing this, I'm focused on right back here being the muscle that works, all right? Not my knee, okay? But because I need that outside muscle to kick in and to be the thing that starts working, okay? So what we like to do is we like to tie those knees together with either a ring band, which is a continuous circle band, or if you've got some TheraBand or tubing or something laying around at home, you tie that together and you work that way. Again, we've got a couple of really strong athletes right now where we had them do, we like to time because we hate to count, where you do 1 minute and go back and forth 3 times. So each side is getting 3 minutes of work. Burn those cheeks right up. It's so great because we're isolating. Again, the bigger the motion that people are doing, the easier it is to compensate. So we're talking about a dislocated kneecap or IT band syndrome or knees that hurt over time. We've got to make sure that all that muscles, all those things are all working and firing. So we start with isolating each muscle group. We get the hamstrings. We get hip extension with the glutes, with glute max. We get lateral motion here, which is the glute med, okay? And then we start adding in rotation and other things. But we start typically laying down or sitting so that you can isolate them. Because, you know, I could say stand up and do that leg out to the side. So many things can go wrong. So many things can cheat through that. So that's where I start with those kind of things. If it continues to be a problem though, I again highly recommend a good physical therapist that does a good manual exam, provides hands-on therapy, okay, meaning they're going to regularly do some type of massage, myofascial release. They're getting in there looking for those muscles that are tender and sore that you didn't know were tender and sore, all right? And they're doing all of those kind of things. And then, again, one-on-one therapy if you can find it, which is why we naturally social distance at Nephew Physical Therapy because we're just doing one-on-one and we're not going from patient to patient. We're focused on just you, and we really focus in on those details so you're getting the right muscle to fire, because again, if it was easy, your body would compensate for it, okay? Excellent questions, everybody. Before my phone dies, I just want to end with one story. And I was thinking about, as I've been thinking about knees and all the people I've been able to help over all of these years, and how many of those people have actually become friends, it takes me back to my good friend Dennis. And Dennis has given me permission to tell part of his story at least. And while his story includes skiing down a mountain and flipping a couple of times, and on that second revolution, losing his ski, ripping everything in that knee, getting casted, which rarely happens, and I was blessed to meet, oh boy, how many years ago is it now? At least 15 years ago. I believe it was a divine appointment to get to meet Dennis. And oh, I've never seen such a tough knee in my whole life. And he worked so hard, and we had to regain all that motion, and it was painful and it was hard. But we're friends. Dennis has become a dear friend of mine. He checks in on me every once in a while. He's kind of, I don't even know how to describe the relationship, right? He's not like a dad, he's not like an uncle, he's a friend, but he has kids of his own and grandkids, all that kind of stuff. And when I think about why we do what we do, I often think of Dennis. I think of this lifelong friendship we now have, where we would have conversations and we would talk about God. And when we were in our deepest, darkest moments, when we were really struggling to get his knee going, that we could still find hope. And so through this very challenging time, today was a tougher day than others, where the emotional roller coaster, where the challenges of what we do and managing kids at home with school and not getting to see our friends and hug them and have those interpersonal relationships. It's tough. It's so tough. But I am reminded that the reason we do all of this is because it changes lives. We're just focused on the physical pain that people have, right? We have mental, emotional, physical, spiritual, all these different needs. But having been a physical therapist for 20 years, that's what it's about for me. It is about giving people hope. It is about walking alongside of them to teach them that God does not want you to be in pain, that it's going to take some work because it is physical therapy. But on those last days and those last visits when we discharge people from therapy, when there is sometimes tears or hugs or those kind of things, that we can go, wow, I got to be a part, whether it's as the therapist or as the person that does the scheduling or sits in the back office. Like, we are a part of helping you do whatever you want to do with your life, and don't let pain get in the way. So on a tired Thursday in the middle of a global pandemic, there's a lot of things that I can't control. There's a lot of things that frustrate me, and there's a lot of things that can be scary. But what I do know is that right now God has tasked us with the opportunity to help people, to feel better, to address their aches and pains, and just to take care of them. So I hope that this weekend you spend some time to take care of you, that you think through how you're taking care of your body, that you move more. And I want you to know you're not alone in this. And if you need our help, we're here. Okay? Because remember, pain is not normal.